Have you ever wondered how doctors actually do it? Like you walk into a clinic with what feels like a completely random string of complaints, right?
Right.
Maybe a sore throat and, I don't know, oddly bloated ankles. And somehow they connect those seemingly unrelated dots to a precise underlying disease. I mean, it feels a bit like magic when you're just sitting there on the exam table.
It really can seem that way from the outside, yeah. But it's actually, well, it's the result of rigorous, structured deductive reasoning.
Hmm.
It's less like magic and more like reading a highly complex topographical map, where every physical sign and symptom is a specific geographical landmark.
And today, we're going to learn how to read that map.
You?
Welcome to today's deep dive. We're looking at a foundational text in medical education, which is 100 Case Studies in Pathophysiology by Harold J. Bruyere, Jr.
Yeah, Bruyere is, he's an emeritus professor with 30 years of experience teaching medical, pharmacy, and nursing students.
Right, and his approach is just incredibly highly regarded because it strips away all the noise.
Yeah. Exactly. He takes real-world clinical scenarios and forces the student to look at the raw data, like the vital signs, the patient history, the lab results, all to figure out exactly what's going wrong inside the body at a mechanical level.
So our mission today is to provide a comprehensive summary of this text. Whether you're a medical student prepping for boards, a young professional sharpening your diagnostic skills, or just insanely curious about how the human body works and how it breaks down, this deep dive is totally custom tailored for you.
Absolutely.
Okay, let's unpack this. The core philosophy of Bruyere's book is that the clinical manifestations of an illness, so the things you can see, hear, and test, are directly associated with the pathophysiology of human disease.
Right, and that's the fundamental truth of medicine. Pathophysiology is essentially the study of disordered physiological processes associated with disease or injury. Bruyere's premise is that symptoms don't just, happen in a vacuum.
They aren't random.
Exactly, not random at all. Every fever, every strange pain, every abnormal blood test is a mechanical consequence of a specific biological system failing, or the body frantically trying to adapt to that failure.
But before you can diagnose a patient, you have to know how to read the data, right? And to do that, you need a blueprint. Bruyere organizes this book logically by organ systems. So you have cardiovascular disorders, respiratory, gastrointestinal, renal, neurological, and so on.
Which perfectly mirrors how a medical professional is trained to think. You categorize the dominant symptoms to kind of narrow down the system in distress. But the real genius of the book is the anatomy of the case study itself. Each patient record is presented with just incredible, meticulous detail.
Yeah, it's not just a quick note saying, patient has chest pain. The book gives you the patient's chief complaints, the history of present illness, or HPI.
The HPI is crucial, yeah.
Then you get the past medical history, the family history, social history, medications, allergies, a complete review of systems.
Don't forget the physical examination.
Right, the physical exam, including all vital signs, and finally, the laboratory and specialized tests.
And all of those components carry equal weight. A common pitfall for novices is to fixate entirely on the chief complaint and the lab results.
They just want the quick answer.
Yeah, they want the shortcut. But the context, the social history, the past medical history, that is what actually solves the case.
It makes me think of debugging a complex piece of computer code. You can't just look at the final error message flashing on your screen. That's just the chief complaint.
Oh, that's a great analogy.
Right. You need to understand the entire environment. What operating system is this computer running on? That's your past medical history. What other random programs are open in the background, draining memory? Well, that's the social and family history. You have to look at the entire ecosystem to find the root cause of the crash.
That's a highly accurate way to visualize it. And to help students navigate that ecosystem, Bruyere provides supplementary tools. The book has a two-part structure, so you have the patient case in the workbook, and then a comprehensive disease summary on the companion CD-ROM.
Oh, right, the CD-ROM.
Plus, there are these incredibly vital appendices at the back. You get APGR scoring for newborns, the Karnofsky Performance Status Scale, normal pediatric blood pressures, and extensive tables of clinical reference values. You have to know what normal looks like before you can identify the abnormal.
Very true. And Bruyere sets a specific, pretty brutal constraint on the reader, doesn't he?
He does. What's fascinating here is that the book deliberately assumes the reader has zero prior pharmacology knowledge.
Which sounds wild for a medical textbook.
Oh, no, it sounds counterintuitive, but it's a brilliant pedagogical choice. By removing the crutch of pharmacology, the learner can't just memorize which drug fixes which symptom. They're forced to rely purely on basic pathophysiology and critical thinking.
So they have to work for it.
Exactly. You have to understand why a disease is happening mechanically before you even think about how a chemical might interrupt that process.
That makes total sense. It forces you to build a foundation first. So let's take that foundation and look at the engine of the body, the cardiovascular and respiratory systems. Bruyere uses these systems to show how vital signs and histories paint a vivid picture of a physiological crisis. Let's look at case 1, which is acute myocardial infarction, or an AMI.
A classic heart attack.
Right. The case details a 53-year-old male. He's playing tennis and starts experiencing this intense, crushing sensation in his sternal area. The pain spreads up into his neck and lower jaw. He's nauseous.
Textbook presentation.
Yeah, so the paramedics arrive, they put him on nasal cannulae for oxygen, start an IV of D5W, which is just a 5% dextrose in water solution, basically sugar water, to keep a vein open, without overloading his system with sodium. Then they give him 325 milligrams of aspirin and morphine. Notably, they do not give him the painkiller meperidine because his chart notes an allergy that causes a severe rash.
And you have to look at his history to understand the underlying risk there. He has a 40-pack year smoking history and type 2 diabetes.
But let me push back here for a second. With a 53-year-old guy playing tennis in the blazing heat, how does a clinician definitively know in that chaotic moment that this is an AMI? I mean, why isn't it just severe acid reflux or heat exhaustion or even a pulled chest muscle from serving the tennis ball?
Well, it's a critical question, and it's exactly why the structured history is essential. Yes, the crushing pain radiating to the jaw is a hallmark of cardiac ischemia, meaning a severe lack of oxygen to the heart muscle. But you synthesize that with the social history.
The smoking.
Right. The chronic smoking has likely severely damaged his vascular endothelium, which is the inner lining of his blood vessels. Then you add the past medical history. Diabetes drastically increases cardiovascular plaque buildup.
So he's already a walking time bomb.
Kind of, yeah. But the real clincher is the nature of the pain. In the emergency department, his chest pain was not relieved by 3 sublingual nitroglycerin tablets. Those are the pills they place under the tongue for rapid absorption.
Okay, because nitroglycerin dilates the blood vessels. So if it was just stable angina-like, a temporary lack of blood flow, that medication would have opened the vessels and offered relief.
You nailed it. The lack of response to nitroglycerin, combined with the fact that the pain didn't change with deep breathing, which rules out pleurisy or lung inflammation, points directly to a complete physical blockage in a coronary artery. Tissue is actively dying. That's an infarction.
Wow, so it's a complete synthesis of the data. Now contrast that heart attack with case 2 in the book, abdominal aortic aneurysm, or AAA. This is an 83-year-old male who comes in complaining of a strange rhythmic throbbing sensation right in his mid-abdomen. But he also has deep lower back pain that he describes as feeling like it's boring into his spine.
And what does he tell the doctor?
He tells the doctor he thinks he just hurt his back lifting firewood.
Right, and this is a classic diagnostic trap. The patient hands you a highly plausible, benign explanation.
The few firewood.
Exactly. But the pathophysiology of the symptom tells a much darker story. The aorta is the massive artery carrying blood from the heart down through the abdomen. If the wall of that artery weakens, it balloons out under the massive blood pressure. That's the aneurysm.
So I'm guessing the throbbing in his stomach is literally his heartbeat pulsing against that ballooned out arterial wall.
Exactly right. That's the physical manifestation of his pulse. But the boring back pain is the alarm bell. The aorta sits right in front of the spine in what's called the retroperitoneal space, basically the deepest part of the back of the abdominal cavity.
Oh, wow.
Yeah, so if that aneurysm is expanding rapidly or beginning to leak blood, it physically presses directly against the nerves of the spine. That deep, unrelenting, boring pain is a massive red flag that the aneurysm is on the verge of catastrophic rupture.
It's terrifying. But fascinating how the mechanics of the anatomy dictate the exact flavor of the symptom.
Speaking of physical pressure and mechanics, we see this structural breakdown in the respiratory system too. Take case 14, chronic obstructive pulmonary disease, or COPD. We have a 68-year-old thin, weak male. His respiratory rate is 32 breaths per minute, which is wildly fast, and his breathing is visibly labored.
Bruyere introduces some complex concepts here, like hypoxemia, hypercapnia, and signs of cor pulmonale, which translates to right-sided heart failure.
And that's the part that always tricks me up. How does a lung disease cause the heart to fail?
It's all about plumbing and resistance.
Yeah.
COPD involves the destruction of the tiny air sacs in the lungs, making it incredibly hard to exhale. Over time, this poor ventilation leads to hypoxemia, low oxygen in the blood, and hypercapnia, high carbon dioxide in the blood.
Well, the lungs are failing at their basic job, which is gas exchange.
Correct. Now, here's where the body's own defense mechanism backfires. To compensate for the low oxygen in certain areas, the blood vessels in the lungs constrict.
Wait, why do they constrict? It's an evolutionary trick. It's designed to shunt blood away from damaged lung tissue toward healthier parts of the lung where oxygen is plentiful. But in severe COPD, the entire lung is damaged, so you get widespread, massive pulmonary vasoconstriction, all the vessels clamp down.
Oh, I see. That creates a massive pressure bottleneck. So the right side of the heart, which pumps blood exclusively to the lungs, is suddenly pushing against a brick wall.
That's the mechanical trap. The right ventricle has to pump so hard against that high pressure that the heart muscle thickens, tires out, and eventually fails. That is cor pulmonale. And when that right pump fails, blood literally backs up into the systemic venous circulation.
That concept of fluid backing up behind a failing organ transitions us perfectly into our next focus, which is the gastrointestinal and endocrine systems. Because that same principle of plumbing and pressure is exactly what destroys the GI tract when the liver fails. Let's dive into case 18, cirrhosis and hepatic encephalopathy.
Oh, this one is a puzzle that requires looking at both the mechanics and the chemistry.
Yeah, we have a male patient who presents with severe disorientation. He has increasing abdominal girth, what they call ascites. He is vomiting blood, which is hematonesis, and he has Tory stools. Now, the interesting piece of social history here is that he stopped drinking alcohol 4 years ago.
Right. But the structural damage to his liver was already done. Cirrhosis is irreversible scarring. If we connect this to the bigger picture, back to our plumbing analogy, the liver is essentially a massive chemical processing plant and a vascular filter. When it turns to rigid scar tissue, blood from the digestive tract just can't flow through it normally. It backs up.
So it's like putting a massive kink in a high-pressure garden hose.
A perfect metaphor. That backup creates massive high pressure in the portal vein system. To relieve the pressure, the body forces that blood into smaller, fragile collateral veins, most notably in the esophagus. These are called esophageal varices.
And I'm guessing they aren't meant to handle that kind of pressure.
Not at all. Because they aren't built for high-pressure blood flow, they balloon out and easily rupture. That explains the hematonemus vomiting blood and the Tory stools, which is just that digested blood passing all the way through the GI tract.
Okay, that makes the bleeding make sense. But what about the confusion? Why does a scarred liver make the patient disoriented?
That's the chemical side, hepatic encephalopathy. Because the liver is failing, it can no longer filter toxins out of the blood. One of the primary culprits is ammonia. Ammonia is naturally produced when bacteria break down proteins in your gut. Normally, your liver snatches up that ammonia and converts it into harmless urea, which you pee out.
But with the liver scarred, the ammonia bypasses the filter entirely.
It bypasses the liver, enters the general bloodstream, and crosses the blood-brain barrier. Ammonia literally poisons the brain. It disrupts the astrocytes, altering neurotransmission and causing severe confusion, lethargy, and, well, it untreated coma.
So the Tory stool and the confusion are both direct symptoms of a single mechanical failure point, the scarred liver. That's incredible. Now, let's move to a different kind of GI issue where the history is everything. Case 21 covers Crohn's disease. This is an inflammatory bowel disease. The patient is an overweight female presenting with a Cushingoid facial appearance. Okay, I'm stopping right here. Why would an inflammatory bowel disease change the shape of someone's face?
It's an excellent catch, and it's a prime example of why Bruyere demands you read the medication histories. The Cushingoid facial appearance, often called a moon face because fat deposits redistribute to the cheeks and neck, is not caused by Crohn's disease itself.
Right.
It's a direct pharmacological side effect of the treatment for Crohn's disease.
The cortico.
Precisely. Crohn's disease causes chronic, severe inflammation of the digestive tract. To suppress that hyperactive immune response and halt the inflammation, patients are often put on high doses of systemic corticosteroids like prednisone. While these steroids save the bowel, prolonged use mimics a hormonal disorder called Cushing syndrome. It completely alters the patient's metabolism, causing central obesity, striae or severe stretch marks on the abdomen, and that classic Cushingoid face. The symptom is a consequence of the cure.
Which proves Bruyere's point, you cannot separate the patient's current presentation from their medication history. Speaking of altered metabolism, let's shift to the endocrine system. Case 53 is a stark look at type 1 diabetes. We have a 13-year-old girl. She presents with vomiting, deep, rapid respirations, and the unmistakable smell of acetone-like nail polish remover on her breath.
She's in diabetic ketoacidosis, or DKA. This is an absolute life-threatening endocrine emergency.
Break down the cellular mechanism for us. How does a lack of insulin lead to nail polish breath?
In type 1 diabetes, the pancreas produces zero insulin. Think of insulin as the physical key that unlocks the cell door to let glucose inside for energy. Without that key, glucose builds up in the blood, but the cells themselves are literally starving, so the body panics. The liver gets the starvation signal and starts rapidly breaking down fat for emergency fuel.
And breaking down fat creates ketone bodies.
Yes, and ketones are highly acidic. As they flood the bloodstream, the blood's pH drops dangerously low. This massive influx of unmeasured acidic ions creates what we call an abnormally wide anion gap on a blood test. Basically, normal blood has a balance of positive and negative ions. Ketones are unmeasured negative ions, so when they flood the system, the mathematical gap between the measured positive and negative ions widens artificially.
Got it. And the body hates being acidic. I'm guessing those deep, rapid breaths are an attempt to blow off acidic carbon dioxide from the lungs to balance the pH.
Right on the money. It's a respiratory compensation called Kussmaul breathing. And acetone is a volatile ketone body, which is why you can literally smell it evaporating off her breath as she exhales.
Okay, let me try to deduce the vomiting then. If her blood is filling up with highly acidic ketones, I imagine that throws her stomach pH completely out of whack, which triggers the nausea.
You're on the right track. The extreme acidity actually circulates and directly irritates the vomiting center in the brain, as well as the gastrointestinal lining. Plus, she's profoundly dehydrated due to a process called osmotic diuresis.
Meaning the kidneys are trying to flush out the massive excess of glucose in the blood, and the sugar essentially acts like a sponge, dragging massive amounts of water out into the urine with it.
Exactly. She's losing fluids rapidly, her blood is acidic, and her cells are starving. The objective signs, the breathing, the breath odor, the labs map perfectly to the underlying metabolic failure.
It's brilliant how everything connects logically once you understand the cellular mechanism. For our final section, we're going to look at neurological flags and nutritional deficits. Here, we see how internal pathophysiology manifests in neurological behaviors and physical development. Bruyere covers headaches in cases 39 and 43, specifically distinguishing between cluster headaches and migraines.
This is a vital distinction because they're often confused by patients, but the clinical manifestations are incredibly different. Migraines are typically unilateral on one side of the head, often accompanied by a throbbing pain, severe nausea, photophobia, meaning a severe sensitivity to light, and sometimes visual auras beforehand. A migraine patient typically wants to lie perfectly still in a pitch-black, silent room.
While a cluster headache is a completely different beast.
Entirely. Cluster headaches are excruciating, often described as a sharp, penetrating, ice pick-like pain usually located directly behind or around one eye. They happen in clusters or cycles, often at the exact same time of day or night. And uniquely, they come with autonomic symptoms on the affected side, like a drooping eyelid, a severely tearing eye, a congested or runny nostril.
Wow, so very physical signs.
Yeah, and unlike a migraine sufferer, a cluster headache patient is highly agitated, often pacing the floor, unable to sit still. The objective physical signs and behaviors completely separate the two diagnoses.
That's a really great visual distinction. Now, the final two cases we'll look at, 96 and 97, delve into nutritional disorders. Case 96 is a 16-year-old girl who fainted in gymnastics class. She presents with bruises and a laceration on her forehead. The diagnosis is anorexia nervosa.
Fainting and bruising are clear clinical signs here. The severe prolonged caloric restriction in anorexia leads to profound hypoglycemia, low blood sugar, which literally deprives the brain of energy, causing the fainting or syncope. But the bruising reveals something deeper. The extreme malnutrition suppresses bone marrow function.
Wait, why does the bone marrow shut down?
Because bone marrow is an incredibly high energy factory. It requires a constant massive supply of calories, vitamins like B12, and iron to manufacture millions of blood cells a day. When you starve the body, the marrow simply shuts down production to conserve energy. This leads to anemia, low red blood cells, and low platelets, which explains why she bruises so easily from minor trauma in gymnastics.
Contrast that with case 97, bulimia nervosa. This patient presents with bloating, significant ankle swelling, and a persistent sore throat. So what does this all mean? How does a simple sore throat reveal a severe psychiatric and nutritional disorder?
It comes down to the destructive pathophysiology of purging. In bulimia, the patient is self-inducing vomiting. The stomach contains highly acidic gastric juices. When that acid is repeatedly forced backward up through the esophagus and into the delicate tissues of the throat, it burns the mucosal lining. That's severe esophagitis, which causes the persistent sore throat.
Let me guess, the ankle swelling and bloating. If they're constantly vomiting, they're losing massive amounts of fluids and electrolytes, right? Does the body panic about the dehydration and start hoarding water?
That's the exact mechanism. When you vomit frequently, you lose massive amounts of potassium and chloride, creating hypokalemia, critically low blood potassium. Potassium is essential for muscle and nerve function, so low levels cause profound lethargy. But to your point about the fluid, in response to chronic volume loss from vomiting, the kidneys release renin, which eventually ramps up a hormone called aldosterone.
And what does aldosterone do?
Aldosterone's job is to ruthlessly hoard sodium and water to keep blood pressure up. This intense, hormonally driven water retention causes the severe bloating and the peripheral edema, which is the ankle swelling.
It's just stunning how clearly Bruyere maps complex psychological behaviors to physical, measurable pathophysiological outcomes.
It's the ultimate lesson of the book. Being a medical professional isn't about memorizing a textbook. It's not about matching a symptom to a drug. It's entirely about cross-referencing subjective symptoms, what the patient feels, with objective signs, lab values, and patient history to reveal the underlying pathophysiology. It's about understanding the complex mechanics of the machine.
Which brings us to the educational focus of our deep dive. We want to make sure you, the listener, are actively synthesizing what we just discussed. So here's a quick review exercise for you to reinforce your learning. I'll give you a second to think about it after I ask. Based on the cases we just explored, if a patient presents in the ER with severe disorientation, a visibly distended abdomen, and a history of heavy alcohol use, even if they quit years ago, what specific neurological complication and what specific gastrointestinal complication should you immediately look for based on their lab results?
Think back to our plumbing analogy and the mechanical failures of a scarred liver.
Right.
You should be looking for signs of hepatic encephalopathy, where the ammonia bypasses the liver and poisons the brain, causing the disorientation. And you're looking for esophageal varices, those fragile, swollen collateral veins in the throat that act like a kink garden hose, which can lead to massive GI bleeding and tarry stools.
If you made those connections, you're thinking exactly how Bruyere wants you to think.
I want to leave you with a final thought to mull over. We spent this entire deep dive discussing the profound importance of combining physical examination, patient history, and lab results to solve the medical mystery. But we live in an era of rapidly advancing medical technology. We have AI diagnostic algorithms, continuous digital biometric monitoring on our wrists, and instant lab results on our phones. As we rely more and more heavily on these digital data streams, how will that shift the importance of the classic hands-on physical examination and the nuanced conversational patient history that we focused on today? Will the art of physically examining a patient become a lost skill, or will it become even more vital to contextualize all that digital noise?
That's an incredible question, something for all of us, especially the medical students and young professionals listening, to really consider as the field rapidly evolves. Thank you for joining us on this deep dive into the fascinating, muddy, and ultimately incredibly logical waters of human disease. Keep questioning the why behind the symptoms, because the human body is a machine, and every symptom is just a machine trying to tell you exactly where it's broken. Catch you next time.